Stephen Thomas. He's Professor of Health Services Administration and Director of the Maryland Center for Health Equity. He is in the University of Maryland School of Public Health, and he wanted me to remind you that the flagship University of Maryland is in College Park, Maryland, because many of his colleagues around the country think he's from Baltimore, but he's not. So Dr. Thomas is one of the nation's leading scholars in the effort to eliminate racial and ethnic health disparities. And Dr. Thomas has applied his expertise to address a variety of conditions from which minorities generally face far poorer outcomes, including cardiovascular disease, diabetes, obesity, and HIV/AIDS. Dr. Thomas is particularly interested in how the legacy of the syphilis study at Tuskegee has impacted trust and influenced the willingness of African Americans to participate in medical and public health research. So with that, we welcome Dr. Thomas.
Thank you very much, Dr. Kors. They have me all wired up. What an amazing space. I don't think I've ever spoken in a space like this, and what it does, it really means that this is about a conversation. This is not a lecture. And it reminds me of something that the Irish poet W.B. Yeats said, that education is not the filling of a pail, but the lighting of a torch. And that's what we need to do today. We need to light a torch that will shine some light on these dark days that we're in today. Now, people ask me as I walk down, oh, how are you doing? And the typical response was always, fine. Is that what we do in America? Fine. But now I have to really think, do you really want to know how I'm doing? Because it depends on if I looked at the CNN feed in the morning or the front page of the newspaper. I had to turn all my alerts off because they were going off so much. So we're going through an interesting time in our country where some of the themes that we're going to talk about today are in your face. If you've ever thought we've gotten beyond issues of race and ethnicity, all you have to do is look at the newspaper. So, as you can see the title of my talk, and I've made some adjustments. This is not going to be an epidemiology of clinical research trials. I think you all can read and know that. But it is really about what the communities are telling me, and maybe any of you who are working in the community. They're sick and tired of being sick and tired. They're sick and tired of being poked and prodded. And after your articles come out, guess what? They're still sick. They want action. And so I've titled this, Less Talk, More Action. And how do you mobilize a community-engaged research infrastructure to eliminate health disparities? And to build these infrastructures from these institutions are not easy. Maybe I'll learn more about how it's done here at the University of Colorado. But in many places, if you have a grant, you can do it. When the grant goes, they're not interested in the community anymore, okay? We've got to work on that. So I'm from a land grant institution. Taxpayers in the state of Maryland pay for us. And you know what increasingly they're asking our president when he goes to the state legislature? What are you doing for the people of Maryland? And I'm pleased to say that his response is some of what you're going to see. The other observation is this image here, which was done by one of our undergrads during the celebration of the anniversary of the Civil Rights Movement. And then I realized that what I may take for granted in terms of history, our entering freshman class was born in the year 2000. And so I put this up, and I have to check. Do you know who this is? Okay? So we cannot take for granted how we've gotten here. So we'll see if the technology works. I'm hitting the button, my friend. I'm hitting the button. And so it was 17 years ago. I was here in Denver doing work on our National Bioethics Research Infrastructure Initiative, and I had an opportunity to meet Dr. I'm going to look because I'll mess it up. I had an opportunity to meet Dr. Hussein Weena at University of Denver. Did I get that right? And we spoke to the leaders of the Latino community, Chicano community, who gave us, again, layers of insight that many of our investigators may not fully appreciate. Sometimes we go into these communities with our data collection, our analysis, and we leave them worse off than had we not come. And the reason I say that is because our data sometimes describes their neighborhoods as hot spots, deserts. You want to live in a hot spot? You want to live in a desert? That's where you want to buy your house? And when the question's raised, well, what are you going to do about it? That's always somebody else's job, who sometimes doesn't show up. So if we're going to count it, if we're going to measure it, if we're going to collect it, we better do something about it. So I'll do a few commercials. This is just one. And I'll make sure that you have this, and it's up on our website as well. Our core theme, we moved to the University of Maryland in 2010. And my entire research team was recruited there from the University of Pittsburgh, where we had been for 10 years. And the University of Maryland recruited us to create and launch the Maryland Center for Health Equity. And I say that because it's very important what kind of institutional commitment you have to do this work. So our core values encompass building bridges, building trust, building healthy communities. Now, I think this is an important required reading for all of us, and it's titled Social Justice, the Moral Foundation of Health and Health Policy. The moral foundation of public health and health policy is social justice. And it hasn't been until recently that some of my doctoral students, when they say the word social justice, find themselves sometimes having to defend it as if it's some bad word, that it somehow makes them automatically liberal or automatically in a certain kind of political persuasion. That is not the case. So one of the things about public health, that animates public health, that gives public health a heartbeat, is our commitment to improving well-being by improving health, and a focus on the needs of the most disadvantaged. So that's what I'll say to you. By focusing on the needs of the most vulnerable, of the most disadvantaged, is where we find our calling. Many of the medical students and other health science students who come into the profession, that is actually what they want to do. But something we do to them along the way of their education can, what can I say, stamp it out of them, diminish their spirit, and make them less open to embracing the full humanity of the most disadvantaged. So I would like to encourage us to look to Madison Powers and Ruth Faden's seminal book here on a moral foundation for public health, and recognize that that's not a silo separate from medicine, separate from nursing, separate from pharmacy. We've got to break these silos down and focus on the people that we say we are here to serve. So, I'm here in a room full of academics, and what's amazing, you all have microphones. Could get scary here. But I'm wondering if we can agree on some things. And here's where the community gets upset with us, because we can spend a whole conference on definitions. So I wonder if we can agree on what it is when we say health disparities and health equity. And if I point to you, it's just to see if we can even have some of this conversation along the way. So this comes from Healthy People 2020, the nation's roadmap for improving the health of the American people. And I think this is a website that hasn't been sanitized, hasn't been changed. I think this is still there. If it's not, we should all demonstrate. Health disparities are not simply a difference in an incidence or prevalence rate, people. A health disparity is a difference that's actually caused by something. It's caused by social inequality. It's caused by systematic discrimination. Okay? It's caused by environmental disadvantage. That's what a health disparity is. So you walk in a room and someone's giving you this epi analysis of all these differences in death rates and life expectancy, and they never mention what might be underlying it. I hope that as a result of being in this conference, you're going to raise your hand and say, can we agree on what it means when you say health disparity? It's not just a difference. And what is health equity? The attainment of the highest level of health for all people. In this context, we would say it's the attainment of the level of health of the most advantaged people in the society. And guess what? If we did that in the United States, we would have a low bar, because there are many countries around the world with much better health outcomes than we have. So one of the things that I'm going to use to kind of focus us is what's called a wicked problem. Raise your hand if you know what a wicked problem is. I'm glad we don't have that many. We might get you some help here. A wicked problem. Some people run from wicked problems. We run to wicked problems. A wicked problem is an issue, social, cultural problem that is difficult or impossible to solve. And these are the reasons: incomplete, contradictory information. If we had a lot of time, Dr. Kors, we'd unpack that a little bit. And hopefully we can cycle back to it. What are examples of contradictory and incomplete information that you're faced with? The number of people and multiple opinions. All I got to do is say gun control. Multiple opinions. Controversy. Even after tragedy, we can't even talk about it. The large economic burden. If we open that lid, there are costs that will bury us. Look what's happening in Flint. The fact that complex problems are typically offloaded to policymakers or written off as too big or cumbersome to solve. That's when we run to our silos. That's somebody else's problem. So wicked problems are the holes in our safety net where the most disadvantaged members of our society are falling through. And so keep that in mind as we move forward, because I think that when I took some of the epi slides out, I realized that what people are missing, in my opinion, is the context that continues to fuel and drive these disparities. And that context means that we need to pay attention to history. And so in that context of understanding the social context for health disparities, in this image here, as you can see, I'm going to pull my themes from civil rights movement. I'm going to pull my themes and some of the images from the experience of African Americans, but that could just as easily be a Havasupai Native American there. That could just as easily be a Latino. That could just as easily be a Muslim. We're talking about people who look to the civil rights movement as their path to being fully integrated in our society. And so the ultimate aim must be, we got to step back from the microscope, so to speak, step back from the clinical details of any particular patient population and say our ultimate aim must be to uncover the environmental factors beyond the biomedical model. Now we're asking you to take on the social determinants of health and to address a broad range of issues, including breaking the cycle of poverty, eliminating environmental hazards in homes and neighborhoods, even in your neighborhood. I was being driven here. My host said, I said, oh, that looks like a place for a new building. Because it seemed like if you got an open space, a building's coming. They said, well, no, that's a asbestos pit. Really? An asbestos pit? In your own neighborhood. Do you have wind here? Do you have dust here? Does it blow things around? And to develop effective intervention programs tailored to the community. Don't just take something off the shelf and put it in Spanish. Say this for the Latinos. Take something off the shelf and put a black face on it and say this is for the African American community. We're talking about tailoring in ways that are sensitive to the history of that community. And so I can assume, Dr. Kors, that this is not unknown to this audience. And I only use it because we don't have time to do all the other examples. There was a time in my, well, let me see the hands, show of hands. Okay, this is, if I had a photograph of that. Yeah, come out here and take that photograph. Put those, yeah. Now, if you've heard of the Tuskegee Syphilis Study, raise your hand. In my career arc, I can remember when no hands went up. No hands went up. That's our progress. Now that we know about it, what are we going to do about it? So you might know the surface, and we'll take it a little bit deeper. Because when we talk about community engaged research, when we talk about cultural tailoring, when we talk about building trust, when you read the definitive book, Bad Blood, by Jim Jones, a medical historian, he describes how the investigators used anthropologists to go door to door and interview these people living in the rural South, to learn their fears, to learn their beliefs. And it's probably one of the best examples of what cultural tailoring looks like. Cultural tailoring, there's no valence, right or wrong. It's what you do with it. So the real story is, what did they do with that cultural information that they gathered? One of the things they did was to realize that people did not have access to health care. People did not see doctors on a routine basis. They looked up to physicians. They trusted them. And so what they did in doing their work, they were gathering blood samples. They would literally have all their materials, their lab materials, phlebotomy material in the trunk of the car. And they would do this data collection out in the cotton fields where these men were working. They gave one message to the men, that they were doing work to help cure their bad blood. Has anyone ever woken up with a headache? Bad blood. Has anyone ever had that tired, run-down feeling? Bad blood. There's nothing stigmatizing about bad blood. They didn't think that these men who were sharecroppers, poor, and illiterate would understand what a spirochete was. Okay? So when we start changing our language to be more health literate, are we changing the meaning? Are we somehow taking away the potential risk? So they drew their blood in the fields. They told the men they're going to cure their bad blood. they told the plantation owners they're going to help their workers be able to do more work. You follow me? Different messages for different audiences. And the farmers let them then come in and draw the blood. So the Tuskegee syphilis study took place from 1932 to 1972, the longest non-therapeutic experiment on humans in the history of medicine and public health. And when the story broke in 1972, this editorial cartoon and editorial cartoons like it and editorials ran in every newspaper across the country. But I picked this one on purpose because you see what the caption says? Secret Tuskegee study. It was never a secret. It's just that most people don't read our journals. I mean, we read our journals. So when we read an article that says 20-year retrospective of untreated syphilis in the Negro male, I mean, we're reading those articles. It wasn't a secret. But it's that other part. Free autopsy, free burial, plus a $100 bonus. So I asked you about how did they use the cultural information. One of the things they had to do in a study like this, natural history study of what would happen if syphilis went untreated, they had to do an autopsy. And these poor farmers, number one, didn't know what autopsy was. And then when you explained to them what it was, they definitely don't want to do it. Okay? So here was the incentive. For those in the study, we would give you burial insurance. Now, this is a time when people of this socioeconomic status were buried in seed sacks. Okay? So you live your whole life buried in a seed sack. But if you join this study, your family will not have to bear the cost of your burial. You'll be buried in a casket. All of a sudden, you live poor, you die like in the middle class or better. So the men said yes. So I use this to say to us, when we have our incentives, when we learn these triggers and cues in the community, to what end? Is it to empower the people to take charge of their own health? Is it to make them more informed decision makers? Or is it to get them to do what we want them to do? All I want you to do is ask yourself the question, look in the mirror, because I can tell you in 1972, when this story broke, none of those investigators thought they were doing anything wrong. None of them. And the study was still going on when it hit the front pages of the newspaper. 1932, 1972. It wasn't until 1997 that there was an actual apology to these men. There were only 8 of them living at the time. And it was President Bill Clinton who issued the formal apology. And for many of the men who were in their late 80s, they were, think about this, a poor sharecropper from rural Alabama in the White House with the President of the United States. They accepted the apology. But many of their family members were very angry and did not accept that apology. An apology means I'm sorry, from a president who wasn't even alive in 1932 when the study began. What we need to do is move towards atonement. It means making things better. And I would submit to you that the national campaign to eliminate health disparities is part of that atonement. The fact that these stories now don't just live in our journals, they live now in the broader society. For Tuskegee, it lives in the HBO movie, Miss Evers Boys. It lives in the jazz CD by Don Byron, Tuskegee Experiments. And who would have imagined there's a whole comic book series about it? Truth, red, white, and black. Now it's living in the broader society with artistic freedoms being taken that are not necessarily adhering to the historical facts. But I would submit to you that these modes get a lot more penetration in the broader society than any of our medical journals. And the speed at which this transformation is occurring. So now if I say to this audience, how many of you have ever heard of Henrietta Lacks? Now, we didn't have to take 20 years to get there, right? They all know about it. And that book is a bestseller by Rebecca Skloot. And Rebecca Skloot was sitting in a class like this, learning about biology. And a professor talked about these cells. And she asked a question, simple question, what's HeLa mean? Where does that come from? And he did not know her name. He said, I think it came from named after the person. He didn't know, but it bothered her. It bothered her that he didn't know. And so she began her investigation. And the end result was this book that's now a bestseller and going to be, if it's not already out, a movie. And they never thought it would get, she never thought she'd even find a publisher. So you cannot, when you are stirred, something's wrong, something's not right here, you can't just sit on that. Those vulnerable, most disadvantaged members of our community are counting on you to have a compass, an ethical compass, to stand up to power when you see wrong. So one of the things that we worked on to address the issue of improving the diversity of participants in research was a grant we received from the NIH called the National Bioethics Research Infrastructure Initiative. And one of our scientific products is this interactive website called Building Trust. And it's my hope that you might find a use for it, a way in which you introduce these topics and themes to the community, and a way in which we can have our investigators sensitized to the complex issues around recruitment. Now, if the technology works, I'm going to have my friend hit a button, and I'm going to take you, and just go to full screen and don't start it yet, though. I'm going to share with you one of our vignettes, and I also want to. So yeah, let's do that. I'm gonna share with you one of the vignettes from a real story, a real person, and his name is Mr. Green.
William Green is a 65-year-old African-American man with 3 grown children. For 15 years, he worked on the loading dock at the local Walmart, but was laid off after suffering a non-work-related back injury. Eventually, he found work as a security guard at a bank, but he currently has no health insurance. 1 year ago, Mr. Green noticed blood in his urine, but initially he was too embarrassed to mention the problem to anyone. After a few weeks, he began to feel pain on urination and went to the emergency room. At the emergency room, Mr. Green received a hurried examination and was given a prescription for antibiotics. After a week on the antibiotics, he returned to the ER since there had been no change in his symptoms. At the emergency room, he received a prescription for a second type of antibiotic. Once again, Mr. Green saw no improvement in his condition and returned to the ER. A third doctor suggested that he undergo a cystoscopy. It took Mr. Green 2 months to save up the $750 for the procedure, which revealed cancerous cells, and subsequent work has revealed bladder cancer. Today, Mr. Green will meet with an oncologist who would like to enroll him in a clinical trial to study the effects of a new cancer drug used in combination with the current standard 2-drug treatment combination.
Mr. Green, unfortunately, with the late diagnosis that you have, it has limited our options for how we can treat this. But what I can offer you is we do have a clinical trial that we've just begun that I'm researching at this point, where we have a 3-drug therapy. I really believe this would be your best option at this point.
Wait a minute. Don't you have anything positive to tell me? I mean...
I'm sorry. Unfortunately, at this point, we're not looking that this is something that could be curable, but what we can do is hopefully arrest its development.
Doc, I've been through hell. You know, this thing started a year ago. It scared the death out of me with blood coming out of my urine.
I realize
too embarrassed to talk to my wife about it.
Unfortunately, with the delay that you had in seeking treatment.
I went to the emergency room 3 separate occasions. The first time I stayed there 2 hours and waited for a doctor who spent less than 10 minutes with me. Took a urine sample and sent me on my way. It was like I wasn't even there. A week later, I'm still bleeding. I go back to the emergency room. I wait another 2 hours. The doctor doesn't stay as long as the first one.
I understand. I have read.
Tell me this, doctor.
Mr. Green, I have read your chart.
I go back a 3rd time, then they tell me I got to have some cystoscopy or whatever the thing is.
Cystoscopy.
Why can't I have the surgery?
At this point, the surgery would not be something that would be beneficial to you. This clinical trial that I am doing now, we are hoping to look at a 3-drug therapy that will address the problem from another angle. Normally we do only a 2-drug therapy. That's what's standard now. But we're hoping that this 3rd drug therapy will come at it from a different angle, and that although we can't cure the cancer at this point, we could prolong your life, arrest its development a bit.
Prolong my life?
Yes.
What are you telling me? I can't have the surgery, so what are my chances without the surgery?
On average, with the standard 2-drug therapy at this point, we're looking at 9 months. But what I would like you to take a look at is this information I have on the clinical trial that we are starting. Now, the one thing that we do need to be aware of is whether or not you are diabetic. Do you have any history of diabetes in your family, or do you know that you are diabetic yourself?
No, I don't.
Okay. That would be our first step, that we would have you tested for diabetes. If you are diabetic, that would eliminate you from the possibility of joining this trial. But that's where we would like to start. So what I would like to do is set up an appointment with my nurse out in the waiting area so that we can start this right away, get you in the loop, and get you started here.
I got to talk to my kids about this. I mean...
Mr. Green, obviously you're aware that time is of the essence.
Yeah, I know, and I know you don't have a lot of time. I know you're a big man, and I see all the people following you around. You're very important, but what...
Just write the first thing that comes in mind down. Maybe a word. So go back one. Keep it. You stay right there. So let's see. How many of you know a Dr. Archer? Look at the hand. You see Dr. Kors, there's the hands are like this. How many of you know Dr. Archer? Truth be told, there are a lot of Dr. Archers out there. The question is, are we training more Dr. Archers? I love there's a sign out there on your campus that says, we don't teach nurse practitioners. We invent them, or something like that. I love that. There's something we're doing in the socialization process that leads to what you just saw. And when I'm in a room full of physicians, nobody knows a Dr. Archer. Nobody, that definitely doesn't happen here. But these came from real people, their narrative, their experience. They come to your hospital for care. They don't come to your hospital to necessarily join a clinical trial. And so you could see all the complexities play out. With more time, we would unpack all of that. There's a part 2 after we put Dr. Archer through our training program, and he does a much better job, but we don't have time to see that one here. But there are simple things he could do that would really make it more humane. And we went around the country gathering these stories, including Colorado and Denver, and working with reenactors. We used your simulated patient model, have simulated clinical trial participants to produce these vignettes to stimulate conversation. So I heard one word that said coercion. What else? What did you write down?
Horrific.
Woo! Other words, other terms. What did you write down? Self-serving, condensation, dismissive, no empathy, uncaring. In our buildings, and you have this huge cancer center. I said to my host, I said, the cancer center looks bigger than a hospital. I mean, it's huge. So they come for care, and clinical trials are obviously part of that. But that's in like a different world. He actually was in a different language. He was not picking up on, when he said, I got to talk to my kids about this. Well, you already delayed. That's your first, you can see it play out, the burden on this man. Okay, so I really would encourage you to kind of kick the tires on building trust. We have a number of both vignettes and solutions. It's not just problems, it's also solutions. And I want to give a special thanks to one of your colleagues here who helped put all this together. And that's Miss Malia Hember. Raise your hand, Malia. Give Malia a hand, will you? So Malia was our first hire right out of her master's program. And we threw her right in the deep end of the pool. And she was actively involved in helping to produce this particular product. And so there are modules. We have modules for the community and modules for the researchers. For this slide, just highlighted the researcher. We're trying to create more self-reflective investigators. And you can see the range. There are 7 modules there. And Dr. Kors, with time and opportunity, it would be a nice, interesting study to see if an educational intervention can help improve self-reflective characteristics of the kind of investigators you want at your institution. So I'm going to rush to the finish line because I want to make sure we have time to talk and share with you what a framework looks like. If all you do is wait for the patients to come to you, they're already sick. And when minority patients come to you, guess what? They're like really sick because they wait so long and they don't want to be here. We want to bring these topics up in the community, in settings that they trust, in venues that they believe in, rather than for them to hear the word clinical trial for the first time when they're given a diagnosis of a cancer. So we published this in 2011. It's called Toward a Fourth Generation of Disparities Research to Achieve Health Equity. And it looks a little bit like this. And you can kind of position yourself on the continuum, and you know colleagues who spend their time doing data analysis, usually secondary data sets, documenting the existence of the disparity. Tons of articles, tons of books, people build their entire careers just doing that. You never have to leave your office. Second generation disparities research, the reasons why. Oh, they're dying before their time because they're poor. They're illiterate. They have no access to care. They live in a food desert. Never have to leave your office. Good data set, you can do second generation disparities research. Third generation disparities research, promising solutions. These are the clinical trials. These are the randomized clinical trials. These are the gold standard of what works. Yeah, for a lot of this, you have to leave your office. But unfortunately, what happens when we publish our results, even when it works, we don't disseminate it. We don't spread it. We don't get it out of our journals and into the community where it's actually implemented. We know now more than we've ever known about actually how to prevent disease. But we got to get it out of our journals and implement it in the community. And so fourth generation disparities research builds on all of that foundation. It takes race into consideration up front. It's not simply a variable to explain away. Race is front and center. And the other thing that's front and center are the structural or the social determinants of health. Okay? So here's what fourth generation disparities research looks like on the ground. In 2001, the Department of Health and Human Services launched this campaign called Take a Loved One to the Doctor Day. Who knows about Take a Loved One to the Doctor Day? It was really a great campaign. You guys paid for it. It was your taxpayers. When we saw the campaign, we realized that a lot of people that we work with did not have doctors. But it was a great website, templates for press releases, all kinds of materials. And so we just turned it on its head, and we called it Take a Health Professional to the People. Take a health professional to the people. And over the next several years, we built an infrastructure in one of the most unusual spaces, in this case in the African American community. That was the Black barbershop. Now, I have to tell my white colleagues that no self-respecting Black barber would ever say, I'll get you in and out in 15 minutes. All right, come on now. Help me out here. It doesn't matter how much hair you have, am I right? You're going to be there all day. You're just going to be there, catching up on the sports, catching up on the news. It's a community setting. It is not hair cutlery. It is not supercuts. The mere fact that there's no Black barbershop franchise in the country lets you know these are very, very unique cultural spaces. These are the spaces where social norms are set. These are the spaces where misinformation can be spread. These are the spaces where a doctor's discharge order can be overridden by something somebody hears in the barbershop. Okay? And I tell you that that doctor had no idea there's a barber out there that has that kind of power or credibility. Okay? But when you see this scene, it just makes sense. This young pharmacist, and the pharmacists love this because the pharmacists have said, listen, we're not just pill pushers, we are full professionals. And in this case, their community pharmacy program used these venues in order to really get out of the silos of their buildings and engage a population that in many cases, like this young man here, is definitely not seeing a doctor on a regular basis. Many people were caregivers and they had tons of medication, had no idea what it was, and they bring it to the barbershop and the pharmacist would work with them. Okay? Perfect. And I like this one because you see that everybody has a culture. In this case, this young Jewish physician is wearing his with his yarmulke. And this young Black man with his braids and his leather coat, and yes, it's summertime, but he's cool. Tell the truth. Their paths otherwise would never have crossed. And it's in this moment trust can be built. And we've seen it on the part of the part of the consumer and on the part of the providers. The providers and physicians love this. But you have to till the ground. You have to create that. You have to maintain that so that the investigators can come, do their thing, and leave. The way it works right now, the investigators come, do their thing, and when they leave, the community feels abandoned in many cases. So we've published, and as simple as it looks, so don't run out and just do this. Oh, I know a barbershop down the street. I pass by it on the way to work. There's a level of sophistication here that I want you to appreciate, and we've published it in a book chapter by Meredith Minkler. And I want to thank Cigna, because it's been the insurance companies that have stepped up to say, you know, at the end of the day, we're the ones paying for this. We think we got to do something different. And so Cigna has funded us to launch the Health Advocates in Reach and Research, a network of Black barbershops and beauty salons in the Metro DC area. And our new round of funding is to launch the National Association of Black Barbers and Stylists for Health. And that means that the place you drive by on the way to work might be eligible to be part of the National Association. That will give you more confidence that any health-related information talked about in that space would be evidence-based. And I share this to you because one of the things that we have to do when we go into the community and hear the community's concerns, we have to bring those concerns back to our campuses, share with our leaders. And in this case, sitting in that chair is the president of our university, Dr. Wallace Lowe. And I think the scene maybe speaks for itself. He had a chance to meet his neighbors in a setting he had never been in before. And this gentleman right here is the NIH director of the National Institutes of Minority Health and Health Disparities. In other words, bring people in power into the very settings where the people feel powerless. I'm gonna take a chance and hit a button again and take you into this barbershop. Let's see what happens. We know now more than we've ever known about actually how to prevent disease. And yet we have segments of our community, particularly African Americans and Latinos, dying before their time. So the message, the science of medicine and public health has not reached everyone. And that's why it's so exciting to finally have a corporate partner that recognizes that business as usual is not working, and that they're willing to do something innovative and different. Ladies and gentlemen, just if we can have your attention just for a moment. We're really excited to be here to announce our special initiative. That is our Health Advocates in Reach and Research initiative that brings us to the shop here in Hyattsville to actually launch a health campaign around colorectal cancer screening.
When we've looked at data for health disparities for the last 20 years, people have been talking about it, measuring about it, putting out pilots, and really that gap has stayed the same for 20 years. So whatever the message and the intent was, it wasn't getting out. And what we realized is that for us to really improve health and to close that gap in health disparities, we needed to try a different approach and try a new channel of communication.
We're so happy that Cigna Foundation is really supporting this, and they believe in our concept. They believe that we can make a difference, that barbershops who are in the community, who are part of the community, can be part of the solution.
We are very passionate about improving the health of the communities in which we live and serve. So this initiative with University of Maryland is designed to reach individuals where they can get the information more readily and in an environment that is not threatening and trusted.
We've been working together for the past 2 years, setting the stage for this moment right now.
Everyone comes to the barbershop. We have lawyers, doctors, senators, executives, trashmen, guys who work at, at Safeway and things of that nature. You have all different levels of, of people working and work fields. Many of us, especially in our black community, are missing a lot of information to stay healthy. And a lot of us are actually dying from things that could be prevented. They're going to train us, and we're going to train the community, one by one, in the chair.
The barbershop definitely is the place where we come and we, you know, everybody talks and speaks whatever's going on in their life. You say stuff in here that you may not say somewhere else. Since this initiative has happened, it's being discussed probably on a daily basis. You know, whether we're talking about, hey man, when the last time you had your checkup, or did you go take a participate in this, you know, and it becomes now, it's almost, it has become fashionable to be involved in your self-help.
My father actually was a victim of it, of the colorectal cancer that eventually killed him. This is for real. It's not a game. It affected me directly because of the relationship I had with my father, and to lose him was, I miss him, and you know, I wouldn't want anybody to go through what I went through. So this information that we have here, I think is very vital, and it's gonna, I just hope it changed people's lives.
Give those guys a hand, will you? I mean, they are so authentic. They are natural leaders. And I am telling you, when he says it's become fashionable, we've changed the norm in that shop and everybody who comes in that shop. When our physicians, nurses, pharmacists, public health professionals, nutritionists come into that shop, they're welcome, they're embraced, okay? Those people hear about clinical trials, research, before they walk into a hospital. We want them to be more proactive, seeking out trials, not just waiting until there's no choice. And so, Fred, I'm only showing you this because we were at a big meeting with Robert Wood Johnson, and I had Fred, because the other thing that we need to do is, again, bring our community partners into the settings where we operate. And there happened to be a very famous, I don't know if you know Paul Terry, but RWJ put us at these little work tables, and he happened to be sitting next to Fred. These two men, again, would never have met. Their social networks don't overlap, except for the fact that we were at the Lincoln Lodge, and Robert Wood Johnson brought us in the room together. And 4 months later, this article comes out in Managed Care, as Paul Terry was reflecting on all the meetings he goes to and expects hopefully a good lunch, but nothing much else to happen, and how he was touched and changed by meeting Fred the barber. And this title, this young lady here is an entrepreneur out in New York, very, very successful. A barber, a professor, and an entrepreneur walk into a room. Health equity and the strength of weak ties. Now, weak ties, there's a whole theory, social network theory, about the strength of weak ties. And it's the importance of bringing people who are not in your normal network together. And in those weak ties, there's innovation. There's new insight. And we'll make sure this is available. The next and last, as I head to the finish line, wicked problem is oral health. Now, again, we work with colleagues around the world. We have a research study going on now in Belfast, Ireland. And what you're about to see, they have said to me, this would not happen because of our universal care. But as you can see here, and I want you to take a look at the woman in the wheelchair who's coming in for care. This is called the Mission of Mercy and Health Equity Festival, where we transform our basketball arena into a full-service emergency dental clinic with 110 dental chairs and wraparound medical services. Because when the people show up for the dental care, they bring all their burdens with them. People slept outside overnight. The doors open at 7 a.m. on a Friday. The first person in line was in line 7:30 p.m. the night before. By 1 a.m. in the morning, there were 100 people in line. When I showed up at 5:30, the line was as far as the eye could see. Oral health in this country is a crime. Now, there's a lot of beautiful smiles in this room. And if any of you moms and dads have teenagers that you've put braces on, you know what that costs. But can you imagine never smiling in a family album? Can you imagine the shame of feeling as though you cannot open your mouth at a job interview? That's why they line up. And so as you can see here, 1,260 people were served. We turned over 1,000 people away. That's what the demand was. And this is what the arena looks like. These dentists are private practitioners. Close their office, get back. I'll take one more chance because this technology is really working good, Dr. Kors. I got one more chance here. Hit the button, Dave.
That is such a sight to see hundreds of people being cared for, all this wonderful dental ministry. This is an act of care. Everything the Lord asks us to do to one another and for one another is being demonstrated right here. Just be there for a sister or a brother who has need. What an extraordinary partnership. The Center for Health Equity, Catholic Charities, all under the umbrella of the university. It's extraordinary.
So the Archdiocese of Washington, D.C. is our partner. Yeah, don't autoplay. You never know what pops up. And so I showed you the version that they produced. The university produced one, and students from the School of Journalism produced almost like a 60 minutes piece. That's how many stories uniquely are on that arena floor. There were pan x-rays, digital delivery of the results to the arena floor, to the iPads, three 3D printers that printed permanent crowns on the spot. And in 2017 of September of this year, we had a lab that produced dentures, or they call them flippers. These are people who had lost their smile, car accident, domestic violence. And they literally produced on the same day a new set of teeth. It was transformative. Not only for the person receiving the service, but for the providers. Why are these dentists crying? Why are these hygienists crying? Why are these people hugging one another with gauze in their mouth? We're treated with dignity and respect. There's a lot to unpack there. On that arena floor were also several IRB-approved research studies occurring on that arena floor to tell the story of our citizens 11 miles from the White House falling through our safety net. So what's this lesson here? Let's provide something of value to the people. And when they come, Let's wrap all those other things we know from our epidemiology around them that they need. Okay? Costs $160,000 in fundraising to put that on. $1.5 million in care delivered, and that's an underestimate. The hospital systems brought their diabetologists, their cardiologists, their nutritionists. These are all the people they're trying to reach, they can't reach. And if we had an event like this to come and learn how to lose weight, come and learn how to exercise more, come and learn how to eat better, we'd be hearing crickets. Crickets. Give them something they need, and then wrap all those other things around it. This year in 2017, we worked with a group out of University of San Francisco in California, and we were able to deploy a Mission of Mercy app on their telephones. Because historically, once these events are over, they're nobody's patient. They're lost to follow-up. Till the next time. There are 4 of these events that happened in the state of Maryland. And as public health professionals, as health equity, as 4th generation, we are now the repository of the data stream of all the moms in the state of Maryland. And I can communicate with a hospital system and say, 150 people from your catchment showed up at this event. Out of control blood pressure, hemoglobin A1Cs out of whack. Bring your mobile unit to this location. We'll make sure the people are there. You follow me? How do we get the word out for all those people? Through the barbershops. Through the barbershops. We had 500 vouchers for our partners in the churches and the barbershops. Those people were screened on Thursday, so that on Friday morning, they're the first ones to go to the chairs, so that the practitioners don't have to wait for people to get through registration. Hugely, hugely successful. We have an article in the American Journal of Public Health I'll make sure I send to you. And so at the University of Maryland in College Park, we do not have a dental school. We have a medical school. We do not have a school of pharmacy. We had a full pharmacy at this event. Everybody left with all the meds they needed. And I would submit to you that's some of why it worked. Because on those places that they have all those things, everybody's in their own castle. Everybody's in their own silo. We had to create the kind of space that doesn't exist. You want to talk about interprofessional education? That was happening on that arena floor. Not only between the dentist who's an endodontist and a dentist, who's another kind of specialist, a surgeon, but also the nutritionists and also all the other. There is nothing like this that brings all those professionals together in the interest of what? Serving the most vulnerable. That's why they were crying. That's why they were happy. Because for many of them, they said, this is why I wanted to become a dentist. This is why I wanted to become a physician. This is why I wanted to do this work. And yes, we brought the barbers. And what was interesting, because there's a lot of wait time. You're waiting for your number to be called, for yours. And so I was so surprised. I don't have the line. I just took this photo. But there was a whole line of people, women, men, Black, Latino, white, to get a haircut. And what that did, it set a whole different tone, a whole different atmosphere. We brought in our Clarice Smith Center for the Performing Arts, the choral group. They came and they sang live. We had the men's a cappella. They came and sang. We had a young engineering student with a guitar. He came and sang. We had spoken word. Now, what? I mean, I'm walking out here and I see a piano. Nobody here knows about where art and science connect. That's why the people felt respected. Even though they had to wait in line, even though it was a long day, they felt they were treated with dignity and respect. A lot of the volunteers were escorts, so someone's literally walking you to your next station. Our students are transformed because otherwise they would never meet these people they read about in their books. They didn't even have to leave campus. And I put this up because this is one of our basic science researchers. Her name is Amy Sapkota, works in the lab, doing work, very interesting work on the microbiome. And I asked her about the literature, and she says for much of the literature on the microbiome, there are no diverse samples because people are basically using convenient samples. So long story short, we put Amy through our program. She met with our Community Research Advisory Board, and we deployed her to the barbershops. And here she is collecting microbiome DNA samples in the barbershop among Black men. Okay? It can be done once you build trust. But it also means that we have to be what? Trustworthy. We can't just let anybody into these shops. In the early days, we did that, and we saw people running out to make sure their car was still there. We saw people holding onto their purses, and all that fear and anxiety was exuded in the space. So we said, we've got to put these folks through orientation. We've got to help them deal with their own issues before we put them in the community. But I want you to know it works. So let me close by saying this. There's both danger and opportunity should you follow this path. And the danger is to assume that racism is not relevant. Now, there was a time, Dr. Kors, when I said this, and people would like, well, really, it's not relevant. We're in a post-racial society. We got a Black president. Who would have imagined what a short period of time would do? We're talking about white supremacy, and we're talking about, did slavery really happen? And I mean, crazy. I'm telling you, it is at the core of our society. If we address it, we can take care of all the other problems. But the danger is to assume that racism is not relevant to the scientific pursuit of solutions for the elimination of health disparities. The danger is to assume that some populations will always suffer from premature illness and death by virtue of their lifestyle choice. Those people, that's how they live. Who are we to tell them what to eat? Who are we to tell them how to live? The danger is to assume that the elimination of disparities is impossible and health equity unachievable in a free market society. In a free market society, it is the grocery store business that decides where they put their store. They're not there to help you eliminate food deserts. That's what the assumption is there. But here's the opportunity. The opportunity is to recognize health disparities as an issue of justice, a bioethical issue of justice. Because specific groups were subjected to systematic racial discrimination and denied the basic benefits of society, a violation of the social contract of our democracy. That's where we get our moral grounding. That's what we need to embrace and to recognize as the opportunity before us. We thank our funders and our barbers and stylists and all the people who participated. And let me say to you, thank you very much.